So I made this pediatric hemodynamic digital twin that simulates the physiology, pathology, and other conditions of a child who has come to us with dehydration in IPD settings. So here you can see the user profile we have entered, age, months, and MUAC. We're not mimicking or simulating SAM here. Then we have the vitals. Here you can see the BP is low, so it's kind of simulating hypotensive shock. Here I'll change the capillary refill to 4 seconds, and the rest of the details is almost normal. So here we'll change it to macro drips and we'll generate the fluid protocol. As you can see here, we got the protocol to be 240 ml ringer lactate over 20 minutes, and we have to set the rate to 720 ml per hour. We are giving it a bolus, and expected MAP price is plus 6 mmHg, and to stop infusion if heart rate and respiratory rate exceeds those points. Here we can see the physiological digital twin, where the heart content is shown, tissue fluid content is shown here, and here we are doing a 60 minutes forecast. So you can see the MAP rising as you go till 60 minutes, and the lung water here. You can also see the electrolytes, sodium increasing from 140 to 142 as per ringer lactate's composition. You can see potassium decreasing because because of the hemodilation effect. You can see the glucose also decreasing. We've simulated hypoglycemia risk. Then here is where we can simulate what will happen if we say change the fluid. Now it was 240 ml which we were giving above. Now we'll simulate more fluid in the same amount of time, and we'll see the results. You can see that the tissue fluid here is more compared to here, and this points towards the fact that you might be pushing the child towards pulmonary edema if you give a lot of fluid very fast. Now if I say increase the time duration of the same fluid, you will see the graph changes where fluid is not rising so much, but since we gave good amount of fluid, but the tissue fluid is not rising so much, but since we gave good amount of fluid, our MAP is expected to increase. Now if I increase the same fluid, I'll get even more rise in MAP, and I can see even more increase in the tissue fluid. Now we're going to simulate a child in respiratory distress, so I'll just change the values here and check what the fluid protocol is now. So here we have a safety warning that there's risk of pulmonary edema, and we have to check preps. The tissue fluid column is blinking now. It suggests that there's a lot of fluid in the lungs, and we have to reassess clinical signs. KVO rate is 10 ml per hour. Yeah. We can also try and change the working diagnosis here. So undifferentiated shock, septic shock, and the rest of the parameters. As in when we include them, it simulates the physiology of the child and how exactly the protocols will change. So in this case, I am simulating a baby with septic shock and SAM. So there is 10.8 MUAC. There is septic shock. The age is 18 months and weight is 7 kg. The glucose is 62. So the baby is in hypoglycemia. And yeah, we've selected septic shock. Now I'll generate the fluid protocol. As you can see, we got 105 ml dextrose of a normal saline, Because of Sam Hart, we got infusion rate capped. So we are expecting 1 mmHg of MAP rise because Sam Hart has less contractility and less BP increase in capacity. And here, if we see the metabolites, we can see the sodium rising, but mainly we can see the glucose rising and the trajectory of the glucose rise. In 60 minutes, we are expecting 252. So this models in insulin also, insulin factor. It might not be very physiologically accurate, but then it's probably better than what expectations we could make. So now I'm going to say increase the volume of D5NS that we are going to give to the child. Now you can see the MAP rise to 48, which is expected. You can also see the fluid rising slowly. Metabolites, if we check, you can see a sharp rise in glucose. It goes till 538. It's expected to go till 538 because we have increased the dose. Now the same if I increase the duration, it will take some time to run, but we'll go to some. So it's calculating here, as you can see, the different predictions across time. It's calculating all other factors, hemodynamics, SVR, afterload, mass of the sodium, glucose in and out, and finally now we can see the graph. So you can see that the graph is more as in when the you increase the glucose infusion, the insulin burn rate also increases. So you can see that there is a little bit of gap there and it doesn't increase too much. Now I'm going to give some other fluid, ringalactate of high volume, 335, and duration I'll decrease so that we can see the risk of it. As you can see, you're pushing the child into pulmonary edema if you give too much fluid, and the glucose will continue falling because the child is already in septic shock, which is a high burn rate. You can expect a BP rise, of course, but you can also parallelly expect edema. Now if I increase the same time, the chance of edema is still there. If I decrease the fluid, then the chance of edema should decrease. So we can see the background calculations happening here, and now finally we'll get, so you can see that the MAP has risen to 50, but the fluid of the lung volume is now below the harm level. Thank you.